Hi, everyone. My name is Joe Letourneau. I'm a reproductive endocrinologist and infertility specialist at the University of Utah, and I co-direct our Oncofertility program with a focus on fertility preservation for patients with cancer. So today I'm going to talk to you on behalf of the Ovarian Cancer Research Alliance about fertility preservation in patients with gynecologic cancers. And thank you so much for OCRA, for having me. Thanks to them, and thanks for your attention. I'm going to get started. A few disclosures. I do educational programming for EMD Serono, which is a pharmaceutical company, and then educational video creation for a medical education company called Rune. Neither of those are going to be material to this or mentioned here. Just by way of background to kind of explain what we do at the University of Utah. So the University of Utah, as an academic medical center, is a referral center for a large part of the continental United States. So we try to provide our best possible oncology care and cancer care for patients with oncologic conditions that we possibly can for people in certainly Utah, as well as most of Wyoming, lots of Southeast Idaho, northern Nevada, parts of Montana, even parts of western Colorado and northern Arizona. So we see people from a very large landmass. And in total, just within our state, we have about 12,000 reproductive age cancer survivors that are kind of newly diagnosed each year in Utah, both male and females. We do around 150 to 200 new oncofertility consults per year. So talking to patients who've been recently diagnosed with cancer about their future fertility. We offer services including egg and embryo freezing. We can even do very medically complex cases in our hospital operating room. Many of the other ones are done here in our fertility clinic. We help talk people through medications that could help with their fertility or expectant management, meaning we help them stay very informed about their fertility and decision making about it without necessarily doing a specific treatment. We can also perform more advanced techniques like ovarian tissue freezing and testicular tissue freezing, including even for girls and boys who have not yet started puberty. And some of that's experimental, and we do that under a research IRB. We have a large population database, which we've done oncofertility research within. And our goal with our program is to provide sort of state-of-the-art care, research, and advocacy for access to care. And I'm going to talk about advocacy at the end of my talk today, and encourage anyone who's interested in this topic to do what you can to engage with advocacy so we can help make fertility preservation more widely available. And I also want to thank Dr. Doug Fair, who's my partner and co-director in running this program. Okay, so by way of outline today, I'm going to talk about things in sort of 7 parts. So first, I'm going to talk about fertility, cancer, and quality of life. So sort of why we care about fertility preservation. I'm going to talk about the reproductive system and how gynecologic cancers can affect it. Obviously, they are cancers of the reproductive system, but I'll focus on how I think about it as a fertility doctor. Then I'm going to talk about ovarian and fallopian tube cancers and fertility considerations, and then cervical cancers, uterine cancers, vaginal or vulvar cancers, and then lastly, talk about access to care and barriers to fertility preservation. So focusing first on fertility, cancer, and quality of life, wanted to read a patient perspective. This is actually a patient that we had write a letter about her experience with cancer-related infertility years ago. She's a patient who is a survivor of breast cancer. So her cancer is a little bit different than a GYN cancer, but I think her point is well taken, very succinctly summarizes the way that a lot of people feel. So being called infertile is a cruel reminder of the time I spent with cancer treatments. To be infertile alone would be devastating, but somehow knowing that it stemmed from the cancer treatments is a very bitter truth, almost as if my cancer is still mocking me. I might not have taken your life, but I have taken something else. I'm truly at a loss knowing that my fertility could have been saved but wasn't. Any attempt then would have been better than what I am left with now. So this was a person who underwent cancer treatment but did not get a chance to understand that the cancer treatment could affect her fertility, came to a fertility clinic years later, found out she was infertile, and found out that the cancer treatment itself had caused that infertility. and that she could have possibly frozen embryos or eggs at that time, but was never told that. It was very devastating to her, understandably. So a big focus of fertility preservation nowadays is firstly just making sure we're getting in people's ears and they know that this is a possibility. And then if it's safe, if it's feasible, offering and trying to do the techniques that I'm going to kind of outline as we go forward here. So the reason we think about fertility preservation more and more now is that cancer treatment has gotten better and better. A lot of fertility preservation, and not all GYN cancer is like this, but a lot of fertility preservation is related to the exposure to chemotherapy. So chemotherapy can hurt the ovaries or the testicles. So when people are getting chemotherapy, it can damage lots of cells, including the cancer, but surrounding tissues like the reproductive tissues. They're very actively dividing, which I'll show you in a diagram later. So they draw the attention of chemotherapy. So chemotherapy, is in a way it's sort of old. It's been around since the 40s, but in a way it's kind of like that's not that long ago. So we've really learned more quite rapidly about chemotherapy and about its side effects. So in the last, say, 7 decades, we've expanded the types of chemotherapies vastly, the ways we use them, and so on. But as cancer treatment has really improved in the last half century, what we've seen is as survivorship improves, we get the opportunity to focus on quality of life in survivorship. Knowing that cancer treatment affects family building, this is one of the sort of eminent issues for reproductive age people when they're survivors of cancer is, okay, I was hoping to have a family. I went through this treatment. How do I maintain and achieve that goal of having a family? So there are about 120,000 reproductive age females with newly diagnosed cancers each year in the US. About 20,000 of them are under the age of 18. The risk for infertility can span all cancer types, so diseases all over the body with systemic chemotherapy, chemotherapy in the veins, any radiation to the pelvis, surgery to the pelvis, which we'll talk about, can affect fertility. There are now more than 1 million people in the United States who are survivors of cancers that were diagnosed during their childbearing years. So it's not really a niche thing. This is a big issue for a lot of people. The most common cancers that we think about sort of track population-wise based on kind of who gets cancers when. So most breast cancers are diagnosed for people in their 50s plus, but about a quarter of breast cancer diagnoses occur for people who are in their reproductive years, sort of 20s, 30s, 40s type of thing. Lymphomas are reasonably common, as are leukemias, gastrointestinal cancers, and colorectal cancers, unfortunately, on the rise. Gynecologic cancers, central nervous system cancers, and bone and soft tissue cancers. And what you can see to the right are common types of cancers affecting AYA, that means adolescent and young adult or reproductive age people. You can see sort of a breakdown of common cancers that affect this age group. Fertility concerns for this age group are substantial. This is well documented. The American Society of Clinical Oncology recommends discussing fertility preservation and offering fertility preservation for patients when it is feasible. And both patients and providers share concerns about the complexity of this, and particularly the complexities around cost and safety. So I'm going to talk about that as I go through, and try to remind ourselves that those are very important points for patients and providers. I want to focus on the sort of physiology of this next. So how do the reproductive system and gynecologic cancers interact? So it's self-evident the gynecologic cancers are in the reproductive system, but I want to get a little bit more specific about how we think about this as fertility doctors. So when we think about fertility as a fertility provider, we really need a minimum of 3 things. When we're doing fertility testing, this is basically what we're seeking. Do we have eggs? Do we have sperm? And is there a place for them to meet? Meaning, do we have fallopian tubes and a uterus? And what I've drawn here on the right or diagrammed is a sort of visual of the female reproductive tract. So many of these organs are going to be organs that are implicated in gynecologic cancers. So we have the vagina down at the bottom of the screen, the cervix with a little sperm swimming through it. We have the uterine cavity here shaped like a triangle. We have the fallopian tubes coming off of it, and we have the ovaries here in kind of off-white. So for a pregnancy to occur with intercourse, and there are, of course, different ways that families are built and pregnancies are achieved. So not everyone achieves a pregnancy with intercourse. We can also use a sperm donor if someone does not have a partner with sperm or things like that. But just to illustrate a little bit about physiology based on the kind of modality of conceiving with intercourse, sperm are going to be deposited in the upper vagina with intercourse. They have to swim through the cervix, through the uterus, out to the end of the fallopian tube, where they would meet an egg that's ovulated into the end of the fallopian tube, and that makes an embryo. There's an important point here that's a little nuanced that I want you to know about when we think about cervix cancer later on. The cervix is filled with mucus. That mucus has nutrients in it. It also has pores within it, or channels that allow sperm to swim through. It's sort of like a filter for sperm. It's also an activator of sperm. So I want you to remember a word called capacitation. So when sperm are ejaculated from the penis and they swim through the reproductive tract of a female, they are acquiring an ability to fertilize an egg, a capacity. We call this capacitation. So as the sperm swim through the cervix, the uterus, and the tube, as they're getting ready to meet the egg, they're developing the ability or competence to fertilize the egg. And this is done at a molecular level. So it is important. The uterus sort of trains the sperm in a sense to fertilize the egg. So if we remove part of the uterus or part of the cervix, it's something we have to be wary of with consideration around, could someone conceive with intercourse still? Might they benefit from other fertility treatment? So that'll come up again later. Okay, when the sperms and eggs meet, they form embryos. So the egg has a half package of DNA. The sperm has a half package of DNA. The sperm goes inside the egg. And within the egg, then there is a new whole package of DNA. And this is called a zygote or a one-cell embryo. This one-cell embryo, which you can see on the rightward part of the screen, then divides to 2 cells and 4 cells and 8 cells, and eventually about 1 to 300 cells when it lands in the uterus. So this circle that I'm going around with my pointer here is called a blastocyst embryo. And this is the stage at which we implant in the uterus. This is a stage when we have the development of polarity. So all of these cells, when their embryo is only 8 cells, can kind of be anything. Once we've started to differentiate or have poles, we have one side of us that becomes the early baby cells. This is called the inner cell mass. In this drawing here, this would be like the North Pole of the globe. And then on the other end, the South Pole of the globe down here, we have what's called the trophectoderm or future placenta. And these are the cells that actually allow the embryo to implant in the uterus. So we need 3 things to form an embryo. We need egg, sperm, and then a place for the eggs and sperm to meet to make an embryo that can eventually implant in the uterus. So embryos usually roll out of the fallopian tube, but when we do things like in vitro fertilization, we actually put embryos through the cervix. So I'll come back to that later. Historically, when we're thinking about reproductive cancers, we think about the evolution of fertility preservation for gynecologic or reproductive cancers. Historically, surgery and treatment for reproductive cancers had largely involved removing both ovaries, both fallopian tubes, the uterus, and the cervix for many types of cancer. So this was sort of the standard for, centuries, really. And in the last just couple of decades, there's been more attention paid, as we've paid attention to other cancers too, to trying to help cancer survivors have children, more attention being paid to saying, do we really need to remove all of these organs? Is it safe? Is it equivalent in terms of safety and long-term health outcomes to remove, say, one of the organs, but the one affected by a tumor, but not all of them? And could we do what we call fertility-sparing approaches to surgery? This is the first step in fertility preservation for gynecologic cancer care, is which organs will be treated, which organs will be removed, because that will impact whether we have eggs, sperm, and a place for them to meet. If there's no uterus, for example, someone could still build a family, but they may need a gestational carrier or surrogate to do so. These tend to be complex decisions that will involve both the potential for surgery, removing one or more organs, the potential for chemotherapy, which could affect the remaining reproductive organs, the potential for pelvic radiation, which could have an impact on the organs. And then there are complexities such as cost, the desire to build a family or have, one children or future children if someone already has them. There's a time component to this. If we want to freeze someone's eggs or embryos, that takes weeks to do. And so that can be a stressor here, is do we have the time? And what if we wait to treat cancer in order to do fertility preservation techniques? How does that feel? Is that safe or is it not as safe? And so these are always individualized decisions that require discussion with the fertility team and the oncology team. We want to balance the safety of treating your cancer, number one, but near that, but always your health is number one. But near that, because family building is so important, we really want to prioritize this and make these types of treatments available. And really what we want to make available is the information. So back to that patient that I read the story and perspective from earlier, what we really don't want is people to have this decision made for them. Ideally, we are making this decision with you, or we are following your guidance after we give you the information about what you want to do. And it can be a hard decision, and we'll try to weigh in and let you know what we think we might do. But in general, we want to support your interest in having a family if you want that. And there's no rule. You, of course, don't need to do that. But if it's something you want to do or you want to keep the option open, we want you to know what you can do. Now, it could be that you wouldn't mind doing some aspect of what I'm going to talk about, fertility preservation, but you might say, gosh, I wish I had more time, then I would do it. Or I wish I had insurance coverage, then I would do it. Or I wish the cost wasn't this or that, and then I would do it. And what our decision-making science shows around this is that if you at least get the chance to think about it and make your own decision, you will feel better in the long run than if someone makes the decision for you by not telling you anything's an option. So really, if you're not hearing about fertility preservation options and you're interested, be a self-advocate, talk to your provider. If you're a provider or team member, talk to your patients and make sure this is something that people are hearing about. If people do the fertility preservation techniques, they tend to feel even a little bit better. But just at a minimum, just hearing about it, making your own decision, even if that's no, even if you say, hey, I learned about it, but I don't want to do it, people feel better years later about having made their own decision. I'm going to focus on ways that we can do fertility-sparing surgery. And this would usually be something that your GYN oncologist will talk to you about. And again, I'm a fertility doctor, so I do sort of IVF type things. They do the surgery to remove the organs. So in early stage ovarian cancers, sometimes one ovary can be removed and the fallopian tube next to it, but not the other ovary. So that allows us to preserve fertility because there are still eggs. So we have eggs, sperm, and a place for them to meet. The uterus is still there. Typically, when an ovary is removed and the other one is left in place, it's very common that chemotherapy will be needed afterward. And I'll come back to that later. So that can have its own impact on the remaining ovary. What about early stage cervix cancers? So historically, we would remove the entire uterus for early stage cervix cancers. People challenged that concept and said, hey, could we possibly remove just the cervix or the cervix and a little bit of tissue around it, like the upper vagina? And it is possible to do that, and the outcomes are generally very favorable. And so it's possible to just remove the cervix, but leave the uterus in place. Typically, when this is done, there's a worry. If we didn't do the common historical treatment of taking out the whole uterus, hey, could that cancer come back in the lower uterus? And at some point, when people are done with family building, it would typically be recommended that they may consider to remove the rest of the uterus once they're done with family building. But at least for a period of time, we could preserve the uterus in place to hopefully allow for people to have children. And this can be quite successful. The same with early stage endometrial cancer or uterine lining cancer. This is the most common type of uterine cancer. It may be possible, instead of doing a hysterectomy or uterus removal, which was the historical way to do this, it may be possible to do a D&C or a scraping of the inside of the uterus, removing the lining cells that are cancerous. And then after removing those cells, giving high dose progesterone, which prevents uterine lining overgrowth. So it's a natural hormone. That's its natural role, is to balance uterine lining growth. We give it in high doses, and it can help normalize the uterine lining in early stage uterine lining cancers. Typically, in this case, too, once someone has been completed family building, we recommend to remove the uterus. So some of the tensions with these completion hysterectomy approaches is that we want people to get pregnant quickly. Hopefully, if all things are equal to them and they want to be pregnant, it's ideal to get pregnant on the soonish side. Now, you want to talk about the timing of pregnancy with your oncologist and your fertility doctor, but many people who lose their cervix or who are having, for example, uterine lining cancer, may have other reasons to struggle to get pregnant. And so we really want you to engage with us as a fertility doctor so that you can understand, hey, what else could I do to make this more efficient? So efficiency is important. If we want to do a hysterectomy to keep things safe once you're done with family building, ideally family building will happen soonish so that the completion hysterectomy then can happen soonish so that there's not higher long-term risk that the cancer will come back. So engaging with fertility doctors, if you have eggs, sperm, and a place for them to meet, a lot of times our role is helping it happen more efficiently and more quickly. Okay, so I'm going to now talk about some of the ways that we think about fertility in each of these specific cases when fertility-sparing surgery has been done. So let's say you've done fertility-sparing surgery, or that's your approach, and now you're talking to me as a fertility doctor. So if one ovary is removed or is planning to be removed, generally chemotherapy will be given afterward. And I'm going to say, okay, you will still have an ovary with eggs, and we would then meet the criteria of egg, sperm, and a place for them to meet to achieve a pregnancy. But what I worry about is the chemotherapy that you're going to get. It could sort of take away the eggs in the remaining ovary, some or all of them. So human beings were born with a limited number of eggs. We have about 1 million eggs at birth as female people. By the age of 50, the egg count has gone down to 0. And by the typical beginnings of periods or the start of ovulation, the ages that occurs is about 11 to 13 typically. And by that point, the number of eggs that were at birth, which was 1 million, by the early teens, it's about 300,000. And that number declines over time to 0 at about age 50. So releasing eggs causes periods. Releasing eggs or developing eggs is what causes the release of estrogen. And so when eggs run out, people have hot flashes and signs of low estrogen. So there's typically a reproductive window in which it's possible physiologically for the ovaries and uterus to make a pregnancy. So for most people, of course, the practical nature of this is going to be in their 20s, 30s, and 40s and stuff when they're ready to make family building decisions. But there's this window of time, and it usually closes at about 41. So what we worry about is if cancer treatment closes that window more quickly by destroying the number of eggs that are in the ovary. So, if someone is 23 and they have 250,000 eggs left, we're worried, could chemotherapy make that number 0 very quickly by damaging those eggs? Or could it make it, instead of 250,000, only 1,000? And so the supply of eggs that's left is very limited. So ovaries have sort of two classes of eggs in a sense. There are eggs that are actively dividing or actively developing, I should say, when people are ovulating. And then there are eggs that are kind of sleeping or resting in an egg bank. So eggs themselves are these little gray dots in my drawing here. And the human egg is a pretty big cell, so it's kind of a big gray dot here, and it's surrounded by these smaller black dots. Those dots are supporting cells called granulosa cells or ovarian follicle cells. And the egg is kind of in a house, basically, this little house within the ovary that matures the egg. So each egg has its own little maturation place or egg house called a follicle. And the follicle and the egg are a unit together. If the follicle dies, the egg dies. So the follicle is really the target of chemotherapy here, unfortunately, because it's a very rapidly dividing cell structure. So when eggs are called out of their resting egg bank to be utilized, they go on what amounts to an assembly line, and they develop for about 6 to 12 months, sometimes a little less, sometimes about 3 months. But they go from about an egg with one cell to an egg with tens of thousands of cells around it. So this is why they're susceptible to chemotherapy damage. So as they're going down this assembly line to eventually ovulate, they will draw the attention of chemo, and chemo can affect either the eggs on the assembly line, so the ones that are actively dividing and growing a whole bunch. A lot of chemotherapies target cell division, so those will be susceptible and they could be wiped off the assembly line. So we could have a disruption of ovarian function with no ovulation or fertility for a year or so after chemotherapy, because all those ones on the assembly line were wiped off. And even if there are eggs left to start the assembly line again, it'll take a while for the eggs to sort of reach the other end of the line where we can see activity again. The other thing that can happen is the eggs in the egg bank, which are resting, can be destroyed by really aggressive forms of chemotherapy or radiation, where there are no more eggs to put on the assembly line, and that's basically menopause at that point. So to illustrate this, there are different categories of chemos generally. So taxanes, anthracyclines, and antimetabolites, and there's a few examples parenthetically there that you could see. They affect cellular division. So they're really going to affect those follicles that are getting ready right now. As I'm giving this recording, I'm in August in Utah here. And so someone who has eggs will be developing them for September, October, next March. And if they get chemotherapy now in August, all those eggs are going to be wiped away. for the most part. However, if we hit about a year out from the chemo, we'll start to see that the eggs that weren't exposed to chemo are going to start rolling off the assembly line, and we'll start seeing ovulations and periods and ovarian activity again. So these are kind of lighter chemos as it goes for ovarian damage. And then you've got the kind of heavier hitters, so to speak. So alkylating agents, which damage DNA, or platinum compounds, which also damage DNA. And so these can affect even resting eggs and take them away and take away the egg bank completely. So the egg bank being on the left, circled in blue, and then this other X being on the right, that's the assembly line or the active eggs. And these chemotherapies can wipe out both. So these can put people into menopause right away. And these are used more often for advanced stage cervical cancers. So I'm going to come back to advanced stage cervical cancer later. But fortunately, for the typical types of ovarian cancers for people in their reproductive years, these types of chemotherapies are not as commonly used. So fortunately, when people get chemotherapy for ovarian cancer, it tends to be a pretty reasonable chance that it's not going to wipe out all of their eggs. And this is an assessment that we make when we're talking to people. Are we worried that this chemotherapy insult at whatever age in this window where people ovulate, has it narrowed the window such that there are going to be either no eggs left or a limited number of eggs, where, hey, now the trajectory toward menopause, it's not going to be 50 for the age of menopause. Is menopause going to come at 29 or some younger age? And if menopause comes sooner, that means the window in which someone could get pregnant is smaller because they're going to run out of eggs sooner. So we take into account this when we're counseling people. Okay, do we think you're going to have no eggs, in a year or two when you're done with chemotherapy and you'll never have eggs again? Do we think you're going to have no eggs for a while after chemo, but we're going to see some activity again a year from now, and you may be able to conceive on your own? Or along with that, do we think, hey, maybe there's going to be a window of time when you can conceive on your own, but gosh, if you want 4 children and you have 0 now, in your window in which to get pregnant, we suspect is narrow. That worries us. And that's another reason we think about doing fertility preservation, is not only will it help you get pregnant whatsoever at all, but hopefully with fertility preservation, maybe help you build the family to the complete number that you're hoping for. So things we take into account are age. So when people are younger in age, they have more eggs. If you have more eggs, it's harder to lose them. So it's better to be younger in this regard. The treatment protocol, what's the dose of chemo? How many different types of chemo are being given? What types of chemo are being given? Are they aggressive or less aggressive toward the ovary? So radiation, what's the total dose of radiation? Where is it being targeted? If it's being targeted in the low pelvis, are the ovaries sitting right in that field? And is the radiation going to affect the ovaries and take away the eggs? We also think about people's family history. So people whose mother went into menopause early without having surgery that led to menopause, they're at a higher risk to go into menopause early too. There's a genetic component. So if someone is already at risk to lose eggs more quickly, chemotherapy will probably further accelerate that risk. We also look at egg reserve markers. So there's a blood test called AMH, or anti-Müllerian hormone, which is kind of an egg counter. And then there's also an ultrasound we can do, which is called an antral follicle count, where we can assess how many eggs are present on the ovarian ultrasound. Okay, so that's kind of how we think about who needs fertility preservation. Now I want to talk about how we do it. So I mentioned when people have one ovary removed and they have a localized ovarian cancer, they're likely to get chemotherapy and follow-up. And so I want to think about what we do then. So we worry for some people, especially if their age is closer to 40, or if they're getting more aggressive types of chemo, we worry that the chemotherapy itself could wipe out the eggs remaining in the ovary. So before we go ahead and give that chemo to this patient, what we would hope to do is offer them the opportunity to freeze their eggs or freeze embryos if that is, right for them at this point in life. If they have a partner, they want to do that. Meaning that with embryos, we combine the eggs and sperm together. With egg freezing alone, we don't need the sperm source yet. This usually takes about 2 to 3 weeks. So I mentioned that in the considerations around the complexity of this, it takes time. So that would mean not starting chemotherapy tomorrow, but waiting. And, usually when people have had surgery, we need to wait on starting chemo so they can heal from their surgery. We can do this during the often weeks of healing after surgery. We can do egg or embryo freezing in that time before chemo starts. So usually we don't really delay the otherwise what would have been start of chemo date. But it's something we always talk about the oncology team, or with the oncology team. Another option people ask about sometimes is ovarian tissue freezing. This is a scientifically accepted, clinically acceptable thing that we do. And I'll show you some pictures. It's a very interesting thing. And people ask us sometimes, hey, if you're removing my ovarian tissue, can I freeze it? So I'm going to come back to that and answer that about ovarian cancer. Okay, so when we think about egg or embryo freezing, I'm going to give you a natural menstrual cycle as a reference point. So this is sort of image-wise showing across the bottom or x-axis going toward the right a menstrual cycle. So what's happening within the ovary in a menstrual cycle? So there are these little egg houses, antral follicles. So these blue circles each contain a very small dot that is the egg. What happens is these egg houses, these support houses, these follicles, they grow and they help the egg become mature or fertilizable and help it to ovulate. Usually, there's enough fuel from our brains to grow one egg, and the remaining follicles that are there, they die off, and only one grows. That's why human beings have one baby at a time, typically, as we only release one egg naturally. This, as a sort of side effect of egg development, we're making lots of cells around the egg to support it and make it fertilizable within the ovary and then getting it ready to ovulate out of the ovary. But those same cells that are maturing the egg are also what are releasing estrogen, those granulosa cells. So in a typical menstrual cycle, the estradiol level, which is a sort of fancy term for estrogen, is 100. So I want you to keep that in mind, and we'll come back to that in a second. When we do egg or embryo freezing, what we do is we fuel more egg development. So there's a hormone called follicle stimulating hormone, and we can provide this hormone with these shots right here that you can see at the bottom of the screen. What these do is they give more fuel to the follicles. So if we have a little bit of fuel and there are 20 follicles, one follicle will grow because there's only a little bit of fuel and only one grows. If we give 20 times more fuel via injections, as opposed to just a little bit coming from our brain, we can get those other follicles to grow too. They can also develop eggs. So this is the way that IVF essentially works, is you take shots of follicle stimulating hormone and then more eggs develop. Ultrasonographically, what that looks like is ovaries look like chocolate chip cookies, and the chocolate chips are the follicles, and they grow and they get bigger in size, and we can actually see that happening on ultrasound. So it sort of would mimic what's happening to these blue circles here. They get bigger and bigger, and what's happening is there's basically now 10 or 20, and it depends on your egg count, how many would grow, but just basically many eggs developing in response to these shots. And so that helps us to get many eggs out and freeze many eggs, because not every egg will make a baby. So we need numerous chances to help us improve your chances of having a baby. The levels of estrogen, when 10 or 20 times more eggs are growing than usual, than the just one. If you recall, when one grows, estrogen's 100. When 20 grow, estrogen's 2000. So estrogen goes up when we do IVF, and it's a consideration, especially for uterine lining cancers, which are responsive to estrogen. It's a safety consideration. I want you to know it's safe to do this still, but it's something we think about. Okay, so when we develop these follicles and grow them to get eggs out, we have to take the eggs out of the body. If they ovulate, they'll go in the fallopian tube, or we won't be able to find them. They're too little to see. This follicle structure here is about 2 centimeters by the time we take the eggs out. So we can see that with an ultrasound. An egg is 0.1 millimeters. So it's super small. We can't actually see the egg on ultrasound. So in the rightward picture here, there is a needle coming down into the ovary via an ultrasound here. This is what we're seeing. And these dark circles are ovarian follicles, and the eggs are in there. Each of those has an egg inside. We just can't see the egg. So what we're seeing is dark fluid, which is like basically a watery fluid, and the egg should be floating in it. So we're taking the egg out with this needle that you can see in the kind of the cartoon here. We're aspirating it out. This is a generally really safe thing to do. One consideration as it relates to GYN cancers is the uterus is right here, adjacent to the ovary, and the cervix is, of course, right there and adjacent to it too. So we usually take eggs out by placing a vaginal probe under anesthesia. So basically people are comfortable, they don't remember it or feel pain from it. We poke into the ovary with a needle and then suck the fluid and eggs out. And the closest way to do that is through the vaginal wall. So the vaginal wall is basically adjacent to the ovaries, and the ovaries get kind of big with IVF, and they're right there. So we usually go with a vaginal approach. However, if someone has cervix cancer, the cervix cancer may be in the way. And what I'm particularly worried about with that is we don't want to poke through the cervix cancer and into the ovary and move the cancer cells into the ovary. So sometimes, specifically with cervix cancer, we'll actually, and I'll mention this later, but we'll go through the abdominal wall and then down into the ovaries from the skin of the abdomen and skip the sort of pelvic approach and get the eggs out that way. So that can also be done to avoid spreading cervix cancers. The nature of this is generally quite safe, a very low risk of bleeding or infection or injury. And it's very similar in some senses to drawing your blood. So with a blood draw, we go through your skin and it's kind of a soft, spongy layer of tissue. we use a narrow needle. It goes through, it makes what we call a needle track or a small hole. And we take that needle out, and the sponginess of the soft tissue just springs it closed. Put a little pressure there, a Band-Aid, it's done, no stitches needed. So in the same way that you don't usually need stitches with a blood draw in your arm, you usually do not need stitches from IVF. So we're placing a needle through the vaginal wall and into the ovary, which are both soft and spongy. They too, when the needle goes in, the needle comes out, usually just seal up without a need for stitches. So it's usually a brief procedure that's quite successful. Rarely, this has been done like sort of a few times. We did this at our center a couple of years ago. Really, if someone has an ovarian cancer that is involving both ovaries, or if they have one ovary left, the remaining ovary, we might worry, gosh, if we try to poke into the ovary to take eggs out and there's cancer in there, we might worry that when we poke the needle into the ovary, if it's ovary cancer, and we pull back the needle, that we could pull the ovary cancer out of the ovary. So in the same way that we worry with a cervix cancer, we don't want to place the needle through the cervix and into other tissues. With an ovarian cancer, we don't want to place the needle into the cancer and then pull it back into other tissues. So what can be done, and it's kind of very complicated to do and very rare, this is not routine by any means, probably been done like a few times in the world type thing, is we can actually remove the ovary that has cancer in it. We can do the IVF preparations, so make numerous eggs develop, and then we can take the ovary out. And this is some images that a patient allowed us to share of us doing this at the University of Utah. So we took out an ovary of a patient who had a mass that was cancer, and the only ovary she had remaining, and we didn't want to poke through that mass and spread the cells around. So we kept the mass contained within the ovary. She took all the shots for IVF, but instead of using an ultrasound guided just small poke with a needle, we actually did what we were going to do anyway, which was take the ovary out for cancer treatment. And when we took the ovary out for cancer treatment, we could then very selectively, with an ultrasound outside the body, take the eggs out of the ovarian follicles directly from the ovary. And when eggs release from the ovary in ovulation, they float in the tube with no blood supply. So eggs are used to having very little oxygen. So that's why we could actually clamp the ovarian tissue, take it out, actually remove the ovary, and the eggs still do very well, even though they've been detached from a blood supply. And of course, we're getting them out within minutes. But the point being that this actually worked really well. So we saved a number of eggs for this person, and it was as successful as if we'd taken them out in the other manner, but we were hoping to minimize any tumor spread. The rightward image here is just a picture of the incubator in which we process eggs and things, and the fluid that comes out from the egg retrieval. Okay, I mentioned ovarian tissue freezing as a concept. It's quick, right? Taking those hormones and stuff and getting the eggs out that way, it takes like 2 weeks, 3 weeks. This requires no time at all. The idea is that we're just going to take out a piece of the ovary or a whole ovary and save that instead. And this could be done in a really rapid manner if we had to start chemo tomorrow, for example. However, I don't recommend this in general for ovarian cancer, because right now the science of this is that if we take out ovarian tissue, we can't yet make eggs ready to become fertilized outside of the body scientifically. So we're close to that, but we're not there yet. So we have to, in general, if we're going to use the tissue, put it back into the body. And these are a couple of sort of interesting examples. What's most commonly done, if this is done, is the tissue is placed as little strips back into the remaining ovary, the one that wasn't removed. Or it can be placed as little pieces in the ovary with injection. And what it needs to do is re-engraft or draw a blood supply, and it can, and then it can ovulate. And so if there's no eggs left in that ovary, like that ovary stayed behind, got exposed to strong chemo, but we saved the other ovary that kept eggs in it frozen outside the body, we can put those pieces of tissue back, and they will potentially ovulate. They can make pregnancies and so on. You can even, interestingly, put them in the abdominal wall or in the arm. And that's a picture there that's kind of from many years ago, but usually gets a gasp from people, but that's someone ovulating into their forearm. So it's possible to do this, but it's not usually recommendable, because if you have ovarian cancer, we take the tissue out. We don't want to put ovarian cancer back in your body after you've been treated. This is usually put back in years later. So it can restore hormone function. It can help restore fertility, but it's not usually recommendable in ovarian cancer. Okay, next I want to talk about cervix cancer, particularly localized cervix cancer. So we used to remove the whole uterus, the tubes, the ovaries for most cervix cancers. And in the last couple of decades, this approach called the trachelectomy has become more popular, where we specifically remove in early stage cervical cancers that are still in the cervix and kind of small. We remove the cervix itself. So the uterus is kind of shaped like an upside down pear, and this would be the top of the pear that's kind of near the stem. So the cervix is usually about 3 or 4 centimeters long. as part of the lower uterus, and the upper uterus body is another 4 to 6 centimeters tall usually. And so we're leaving that upper part of the uterus that is attached to the fallopian tubes and the ovaries. And then the bottom part of that upper part of the uterus, so where the cervix was removed, right around here in my kind of hand puppet thing up here, we actually pull that down and that's sewn to the upper vagina. We being your GYN oncology team. So this is a really specialized surgery, but it can be done and generally has good outcomes. You'd want to talk to your GYN surgeon about if it's an option for you. So this is what the tissue looks like, having removed a little bit of the upper vagina, the cervix, and the tumor in the center there. And then some of the tissue surrounding the cervix comes out with it. So back at the beginning, I showed that when sperm swim through the cervix and into the uterus, they acquire capacity or capacitation or the ability to fertilize an egg. If we remove the cervix, we can affect that capacitation. So it's still technically possible to conceive with intercourse for someone who's had a cervix removal, but it probably won't work. And so usually what we're needing to do is do intrauterine insemination, which outside the body, we can capacitate sperm that are ejaculated. So we can kind of process them and then put them in a little tube and then pass them through the lower uterus and up to by the fallopian tubes and drop them off. So we sort of like mimic what would happen in that maturation had the cervix been there, but we skip that. It's also possible that that won't work and IVF or in vitro fertilization will be needed. I mentioned earlier that sometimes it's difficult to get eggs out because we're worried about when we take them out hitting the cervix cancer and spreading it. So always considerate about how we get the eggs out. We're also considerate about how we put the embryo back in. So that area that is sewn back to the upper uterus has a little canal in it, or the upper vagina, it has a canal. So this is where sperm could theoretically go through. This is where we can place an embryo with IVF. This is how embryos are placed with IVF. It's very similar to the insemination process. So that can scar shut. We can get something called cervical stenosis. So if this is shut, we have a uterus, but there's no way to get an embryo in. So there are even very advanced techniques with IVF where we can use our ultrasound guidance for someone who's had a trachelectomy and has stenosis where we can't get an embryo in through their cervix down here or their lower uterine segment remnant. And we actually put the embryo in with a needle, a special needle, and we poke through the uterine muscle as opposed to going through this natural opening here and drop it off through the uterine muscle. So that's an advanced and rare technique, but that's possible too. With advanced cervix cancers, so ones that have left the cervix and moved into the uterus or other places, typically chemotherapy and radiation are going to be recommended. And this is problematic for a couple of reasons. One, once the uterus is strongly irradiated, it's typically not going to be able to carry a pregnancy. So if people have a stage, typically 2+ cervix cancer, they're probably going to need a gestational carrier to get pregnant. However, the other concern is if we need a gestational carrier, that would be the place the sperms and eggs sort of meet. We'll have that person will help to be the source of the uterus. They'll help carry the embryo. We still need eggs and sperm. And so if pelvic radiation is given strongly to the reproductive organs, it can kind of zap all the eggs too. So one of the worries here is that radiation injury to the ovaries can limit our ability even to use a gestational carrier. And so what can be done here is something called an oophoropexy or ovarian transposition. And so just to kind of go back for a second, so I've shown the radiation field here with the ovaries being in it. Okay, so now I'm showing the radiation field here with the ovaries being outside of it. So we can actually detach the part of the ovary that's close to the uterus, keep the ovarian blood supply, which comes from the upper abdomen, and then move the ovaries into the upper abdomen closer to where the blood supply for the ovaries originates. This lower picture on the right here is the surgical image of this being done. So this kind of pole or side of the ovary was removed from the uterine part. They've made what we call a pedicle or kind of loosened the ovary in a sense in its blood vessel so it could move upward. And they're moving the ovary upward into the pelvis. So moving the ovary from down here in the kind of pelvic skeleton, moving up here near the ribs or somewhere else outside the pelvis or way to the side of the pelvis where the radiation field is not. This helps avoid radiation injury to the ovaries and it can preserve the ability to still have eggs in the ovaries for later use. So this is typically done by a GYN oncology surgeon or another surgeon. Okay, uterine cancers are quite common. Fortunately, cervix cancers are less common with things like pap smears and HPV vaccines, but we still see a fair number of cervix cancers, or pardon me, uterine cancers. Uterine cancers tend to occur from what we call unopposed estrogen. What that means is that someone has eggs in their ovaries, but they don't ovulate them, is typically one of the big risk factors for getting uterine lining cancer. So ovulation, as I was mentioning earlier, is what leads to periods. So when people ovulate, they release progesterone. Progesterone organizes the uterine lining, and then when we take progesterone away, it causes that organized uterine lining to detach and shed. When people do not ovulate, which is very common for people with something called PCOS, which affects 1 in 10 women in the United States, they don't get a period every month. And this is why we always say, having a period is healthy. Let us know if you're not having a period, because if someone goes years without a period, what can happen is the uterine lining will become disorganized. It will build up because progesterone doesn't cause it to change and organize and shed. It will build up and become what we call hyperplastic at first. And then the hyperplasia or buildup can become disorganized and invasive and become cancer. So historically, what we would do for this type of treatment is remove the uterus and cervix and possibly the ovaries and things. People ask the question, hey, is it possible if that cancer is just on the surface of the inner uterine lining, which is going to shed or could shed, could we go in there and take that out? Could we scrape it out? And then could we give really strong doses of progesterone and see if we can kind of normalize things and prevent that overgrowth, prevent that hyperplasia, prevent the recurrence of cancer? And it's effective. So we don't necessarily have to do a hysterectomy. And this is a decision to make with your GYN oncology team. We can do, or they would do, a DNC or a scraping of the uterine lining to get the cancer out, and then give very high doses of progesterone to try to organize it. What's then typically done is that at 3-month intervals after that surgery, uterine biopsies or samplings of the uterine lining are done to make sure that cancer hasn't come back. And that's our way of asking the uterus essentially, hey, are you normal now? Did you respond normally to progesterone? It can take some time, so we don't declare right away that things aren't working. But at some point, if we're looking, and the cancer hasn't gone away, we think, maybe these cells are so abnormal they no longer respond to progesterone, which is a normal thing to do. And so they could be so abnormal that we can't kind of stop them at that point with this approach. They may recommend a hysterectomy anyway, but it's very common that this will work and we'll be able to get an attempt then to try to conceive. So if someone's feeling ready to become pregnant and they've undergone this procedure, what's really important to think about is we are going to recommend very likely a completion hysterectomy, meaning sure, we can do this for a while, keep the uterus in place, but we're worried that the cancer could come back at some point. So usually people who have endometrial cancer need fertility treatment because the reason they have endometrial cancer often is they don't ovulate. If you don't ovulate, you don't have eggs. So the eggs, sperm, and a place for them to meet. We don't have the eggs to meet the sperm if they don't leave the ovaries. So we have to establish ovulation. So what I worry about if someone gets localized treatment for their endometrial cancer and then someone says, okay, go ahead and try to get pregnant. If they're not ovulating, they won't get pregnant. We're spending time without the goal that we want of pregnancy, and there's that risk of recurrence or the cancer coming back that's kind of hanging over us. So efficiency is sort of the name of the game here. So if somebody's going to try to get pregnant, people like me like to see people with endometrial cancer as they're making the plan to keep the uterus in place. So we can say, okay, if you clear the cancer and the progesterone works and the biopsies look okay, as soon as you're ready to get pregnant, we want to try to make it efficient to get pregnant. So we want to help you ovulate. That can be done with a simple pill. If that doesn't work, or for other reasons, we may want to say, hey, we want to do other fertility treatments too. And often IVF is needed for people who have had endometrial cancer to get pregnant. And so it's worth noting, because I did mention earlier that with IVF, estrogen levels can go up a lot. And I was just mentioning how estrogen causes the uterine lining, if there's no progesterone around, can cause the uterine lining to become abnormal. So we got to think about that. Okay, you've got a uterine lining cancer, and now we're going to give it more estrogen. Is that safe to do? And it is fortunately generally safe to do because the duration of time that we give estrogen is very short, or that we give IVF shots is very short. So the sort of side effect of high estrogen is a very short amount of high estrogen. And so it seems to go okay. So it's generally safe, even though this is an estrogen sensitive cancer, technically, it's still safe to do things like IVF. You always want to talk to your GYN oncologist about that. And again, this is where this is a team effort with your GYN oncologist and your reproductive doctor, but it can be done. So I don't want to overlook vulvar and vaginal cancers. They are important GYN cancers, but they do tend to rarely present in reproductive age people. They tend to be cancers that occur in the 50s, 60s plus. So we rarely encounter sort of fertility needs and discussions in this type of cancer group. I would say the exception would typically be melanoma. Some people get skin cancer in their vulva or around the vagina, and that can require chemotherapy. So in select cases, we are doing egg or embryo freezing or things for vulvar or vaginal cancer. It's just not quite as common. Okay, lastly, I want to focus on barriers to fertility preservation. So, lots of people that get cancer treatment are understandably very concerned about becoming infertile if they're in their reproductive years. And this concern historically is something that people felt like hadn't been addressed very well. This is a study from, fortunately, a decade plus ago. This is getting much better. But many people, especially with GYN cancers, of course, because you're choosing to do fertility-sparing surgery or not, remove all the organs or keep some of them. Um, you know, these types of concerns about infertility will influence sort of what we do, not only with GYN cancers, but breast cancers and other things. People will say, I'm not sure I want chemo. I'm worried it's going to hurt my fertility. So this is impactful. And many people don't or hadn't gotten a chance to know about their options for fertility preservation, but it's getting a lot better. And this is sort of old data, but we're seeing increases gradually in the number of people that hear about fertility as it relates to cancer treatment, and then the number of people who get opportunities to freeze eggs, freeze embryos, et cetera. Just from a science standpoint, this was a small field of very sort of infrequent scientific questions 3 decades ago. And now it's super common. We're asking all kinds of questions about this and trying to really advance this field. So lots of research papers being done, lots of researchers around the world, fortunately, focused on this. But still, there are some biases. And a lot of them, unfortunately, track with other healthcare biases. So people in historically marginalized groups in healthcare, we see problems with getting access to fertility preservation treatment too. So people get more likely to be referred to see a fertility doctor if they are Caucasian versus non-Caucasian, if they're younger in age versus older in age. So people may have a bias to say, okay, you're 27 and not 43. So you're 27, you must want a baby. The 43-year-old person must not, they're too old. So we want to honor people's wishes and help them understand what they want. So this should be part of the discussion. If someone's 37 and they want a baby, we should still talk to them and try to help. But there is a bias for younger people getting this. People who don't have children tend to be talked to about this more. Hey, do you have kids? Okay, you don't. Let's talk about fertility. Hey, do you have kids? Check. Okay, you have kids. Let's move on. But if someone has kids, it doesn't necessarily mean they don't want more. So we want people to build their families to the completed number that they were hoping for. So we don't want to overlook people that already have kids. People who are college educated tend to be more self-advocates. They might find this if their doctor doesn't talk about it to them. They might do the research to go and meet a fertility doctor themselves. So we see that education does impact how often people get this counseling. And then heterosexual patients get this counseling more often. People tend to overlook the very strong family building desires of people in a same-sex relationship, or people who want to be a single parent by choice, or things like that. And so we want to make sure that, again, we're fulfilling everyone's wishes, meeting them where they are about their family building goals. So it's important to ask these questions of everybody. So information is a big barrier to access. If people don't get the information, they don't know the risk, they don't know the options, they won't do things like egg freezing, embryo freezing, fertility-sparing surgery. If people don't get to us in time, it takes 3 weeks to do surgery. If I see the person the day before they have to start chemo, like I won't be able, or probably 3 weeks to do egg freezing, I won't be able to do it if I see them the day before. So it's really important to see a fertility doctor as soon as you know you have a GYN cancer. Try to get in soon. Sometimes the decision is just too hard to make. It's just really, this is consequential and it's big, and I also have cancer treatment to think about. So it's important to, help with decision making for patients too. Give them support, social work, get family members involved, help them understand what's important to them, because they might be shocked to think, hey, I thought I wanted kids, but I don't know, I haven't thought about that really ever. Now I got to think about it like by tomorrow, so it's hard. Geographically, I mentioned I live in an area where we see patients from 600 miles away. So, it's hard to get here. It can be hard in certain communities, even in urban areas, to have access to certain hospitals with resources, et cetera. There's institutional racism, language barriers, et cetera, that are preventing people from getting this care. There are also complexities about reproductive choice, religious values, et cetera, where people in some religious groups or others, may want to consult with their religious leader to see if this is something that, fits their value system or whatnot. So we're sensitive and supportive of all that. Financial, there's a big cost to this. There's a big cost to cancer treatment. There's a big cost to fertility too. So this is a couple years old. The ranges could be even higher now. But if you're talking about egg freezing, out of pocket costs could be in the, $10,000+ range. That can be a lot if someone's 24 and having to think about this, and their employment is tenuous, or they don't have stable housing, or whatever it is. This can be a real challenge. Fortunately, more and more insurers cover things like egg and embryo freezing, and this is an example from a couple of years ago. But again, if you're caring enough to listen to this, I would hope that, if you have any opportunity to advocate, that you would know that your voice is really important. And patient voices and provider voices have expanded the access to care of this particular issue greatly. So in 2018, there were only 5 states in the United States that mandated insurance coverage for fertility preservation. So insurance coverage for egg freezing or embryo freezing. In Utah, about 6% of patients, we'd estimate, had insurance coverage. Through various advocacy efforts, we've went from, 10 years ago, maybe 10 or 15 million people had insurance coverage for this in the United States, to now over 100 million people have insurance coverage for this, but it's not done yet. So by 2022, there are 11 states that have mandated coverage where this has to be covered under insurance. Utah has some mandates that we worked on with our legislature, but not everything's mandated. But we've taken the level of coverage from 6% of people up to probably 2 out of 5 people now have coverage. So these sort of gains are incremental but important for patients. And I get to see it now, people that didn't have coverage before, the same insurer. I'm seeing, people that are now covered under a new mandate or something, and they're having coverage, and it makes a big difference to be able to go forward and have insurance cover this. So we know it's important to people. We know this is recommended by healthcare organizations. So if you can get in a legislator's ear about this in your state, if it's not covered, please consider it, because your voice is important. So we use different approaches to help expand coverage in general. And a great organization for this is the Alliance for Fertility Preservation, a nonprofit that's done this work all over the country. Combination of legislative approaches, administrative changes at healthcare organizations, talking to different companies, professional organizations. It takes a sort of a village to really alter access to care for this kind of thing. We did achieve success, as I mentioned, in Utah, and passed one of the first Medicaid kind of legislative mandates for fertility preservation. So people with Medicaid coverage are often going to have less other expendable resources and money to pay for things like egg freezing. And so we felt like it was just super important to make this accessible, and had success doing that by assembling an organization of people that care to do so. And it was really great to see sort of government in action in that way. Yeah. So again, I want to thank you for your time. This is my last slide. Happy to be reached out to in the future to talk with your organization if anybody has specific questions. But these are just a few shots of Utah and then my own family there skiing at Alta. But yeah, thanks again for your time. And again, please feel free to reach out in the future. Thanks.